Today we're looking at Chapter 19, Diseases of the Respiratory System, and this corresponds to Chapter 10 in the ICD-10 CM Codebook. As always, we're going to skip over that procedure coding and focus on the diagnostic portions. Just for some reminders, the coder cannot assume there is a respiratory infection based upon a lab report. You have to look for the physician documentation. Nor can you assume a lab report must be positive for a patient to have an infection. If the doctor started antibiotics before the lab test was completed, that infection is not going to show up. So, bottom line, rely on the physician. You should only code for avian influenza or other novel influenza A if the case is confirmed. This is an exception to the inpatient coding guidelines. Atelectasis, the collapse of lung tissue, is an integral part of pulmonary disease, therefore we do not code it. Respiratory failure, always due to an underlying condition, therefore it's important to be sure that the principal diagnosis and the secondary diagnosis are properly assigned. Acute pulmonary edema can be related to heart failure. In that case it's cardiogenic, or it can occur in the absence of heart failure or other heart disease and therefore would be non-cardiogenic. For this first exercise, 19.1 number 4, the couple of things I wanted to say. One is that I have never used this code for an unspecified infectious disease. Most of the time we know what the organism is and we are able to code that infection, but this code exists because I'm sure there are times we don't know that. For the pneumonia code, J17, I want to bring to your attention a couple of things. There is a code first note there that doesn't apply to us, and a long list of excludes one diagnosis to review. We should always review the instructional notes, the excludes one and excludes two notes, just in case it does apply to us. So let's look at that. For J17, you see here, code first underlying disease is here. Those don't apply to us, but look at all these excludes one possibilities. So we really should review all of those to be sure that this code is the correct code. The other thing I wanted you to notice is that this is covered by the general coding guideline for etiology and manifestation. This infection, B99, is our etiology code, and the J17 is the manifestation code, how the infection is being manifested in the body. Exercise 19.1 number 9. This relates to an AIDS coding guideline, which takes us back to Chapter 1, but this is the guideline. If a patient is admitted for an HIV-related condition, the principal is going to be B20. So the guideline tells you what the principal is going to be. That will be your first listed code. And then B59 is the plasma cell pneumonia. I would also make a note in your code book or in your notes somewhere that plasma cell can also be called pneumocystosis or the pneumonia caused by pneumocystis carinii. Exercise 19.2 number 3, acute exacerbation of a chronic asthmatic bronchitis. Our main term is bronchitis, and when we follow our pathway here, we get to J44.1. And when we go to this code, we see an instructional note, code also the type of asthma, and when we look that up, we get J45.901. 19.3 number 7, acute respiratory failure due to intracerebral hemorrhage. I showed you my pathways here, and you see the first time you look it up, it takes you to a different path, hemorrhage intracranial intracerebral. And then when you go here, you get to I61.9, and there is an instructional note under this category, but it doesn't apply to us. I just want to bring to your attention to always look for those. Then there's the respiratory failure here. There are 3 coding guidelines related to acute respiratory failure, and in the real world, I have a note, the coder would need additional information to know which diagnosis should be the principal. If the acute respiratory failure was the reason why you were admitted, then that would be the J96 code first. And if the intracerebral hemorrhage was the reason for the admission, then it would be I61.9. This does not give us very much information to make that call. So I'm just bringing to your attention that if you were a coder in the real world, you would not be relying on this one-liner. You would have an entire medical record to review to help you know which is the correct principal diagnosis. Exercise 19.3, number 9. Chronic chemical bronchitis due to accidental inhalation of chlorine fumes 2 years ago. First of all, you're going to notice that this is a sequela. It's 2 years ago. So many of our T codes and S codes have a 7th character indicating the encounter. This particular one, if you go to the table of drugs and chemicals, substance chlorine gas, and then look in the poisoning accidental column, you get this code with the 7th character S for the encounter, which is the sequela. Then here's your bronchitis code due to fumes or vapors, chronic. And you see when you look up your J68.4 code, there is a code first, the T code, to identify the cause. That helps us know how to sequence these. And then there's an additional code to identify any associated respiratory conditions such as acute respiratory failure. That's not talked about in this scenario. So we would only code that T code for the accidental poisoning and then the chronic chemical bronchitis. And there is a guideline, acute respiratory failure as a secondary diagnosis, which you would need to review. Exercise 19.3, number 11. Admitted in acute respiratory failure due to acute exacerbation of chronic obstructive bronchitis. Here's our path for our acute respiratory failure and our bronchitis. And I want to show you, when you go this path through bronchitis, you get a 0.9, which is a very unspecific code. So whenever possible, you want to code more specificity. So if we start with disease, because we know that chronic obstructive disease is a pulmonary disease, and if we go this path instead, disease, pulmonary, chronic, obstructive with exacerbation, acute, J44.1, a much more specific code and the correct code. And the guideline is acute respiratory failure as a principal diagnosis. But again, I'm bringing to your attention that if you were working in the real world, you would be reviewing the entire medical record. You couldn't rely on one line, in this case, to know which of those diagnoses should be the principal. Exercise 19.3, number 12, acute tracheobronchitis due to respiratory syncytial virus infection. And I put a little blurb here from the internet to describe to you what RSV is. And you'll notice when you start looking up the code, there are codes for 15 years of age and older, and the younger children. I'm assuming this is an older person, and we're going to code it this way: bronchitis acute due to virus respiratory syncytial, J20.5. Don't forget to read those excludes 1 and excludes 2 notes under these codes. 19.3, number 16, an infected tracheostomy due to staphylococcal abscess of the neck. I have the page number here in the coding handbook because this one comes after some discussion about procedures. So I want to be sure you're not missing this, because this is a diagnosis code, not a procedure code. The tracheostomy would be a procedure code, but the complications related to the tracheostomy are diagnosis codes. So it comes under a complication, tracheostomy infection, and we have an instructional note to use additional code to identify the type of infection. Then we look up our abscess of the neck, and we see that for the category infections of the skin and subacute tissues in this category, there is a use additional code to identify the infectious agent. So we look up our B95.8 code, staphylococcal as a cause of disease. So this is your pathway to help you get there, but I want to be sure you don't miss this tracheostomy complications in the coding handbook. Now let's look at some longer exercises that are not in the coding handbook. As I've mentioned in previous podcasts, we're going to start looking at longer scenarios, so you're having to search for main terms and just get used to being able to read quickly through the medical record documentation and knowing which diagnoses you need to code. The physician's diagnostic statement. 15-year-old child is diagnosed with influenza due to novel influenza A with GI manifestations. Reminder, if the physician had stated suspected novel influenza A, it would be coded differently. Novel influenza A is also known as bird flu, in case you ever heard that term. So I have the pathway here. And you see in this case, it is a combination code because you've got the infection, the influenza, and the manifestation, the GI, in the same code, J09.X3. And there is a guideline specifically related to these novel influenza where you code only confirmed cases. And this is an exception to the hospital inpatient guideline. And if the physician had stated suspected novel influenza A, a code from J11 would be chosen instead of the J09.